Good afternoon, everyone. We're so happy for you to be here to join us for our occasional roughly monthly resilience presentation series, hosted by the ETSU Ballad Health Strong Brain Institute. Today, we're delighted to be joined by Dr. Joan Gillece. If you'd like to be added to our email list, please type your email address in the chat and we'll be delighted to add you. My name is Wallace Dixon, and I'm the director of the ETSU Ballad Health Strong Brain Institute. The Strong Brain Institute was founded by a $1 million 5-year gift to ETSU from Ballad Health. I'm truly honored to be asked to help lead and build the organization. The majority of Americans have experienced at least one major adverse experience at some point in their childhood. At ETSU, specifically, 1 in 4 of our students have lived through or may still be living through 3 or more adverse experiences. The goal of the Strong Brain Institute is to use the science of childhood adversity, coupled with mitigation science and resilience science, to prevent and mitigate the negative impacts of ACEs on children's and adults' lives, and to promote awareness and the use of resilience-informed procedures and policies, both at ETSU and throughout the Appalachian Highlands region. We are a resource for people to turn to when they have questions about how best to employ resilience-informed strategies and practices in their workspace. At the end of today's talk, we'll put in an evaluation link in the chat, and during the talk, I'll be monitoring the chat and the Q&A for urgent questions or for questions that may be able to be held over to the Q&A at the end. Welcome to ETSU campus virtually. Today is our first day of school, and it's also 92 degrees in the daytime and then 50 degrees in the morning. So I don't know how to dress every day, but pretty soon it'll be winter and we'll all be good. So at this point, I'd like to hand off to Becky Haas, one of the founding members of the SBI, to introduce Dr. Gillece.
Thank you, Wally, and welcome everyone. It's great to be here today, and it's really great to get to introduce Dr. Gillece. I'm going to read first her the bio that was provided, and then just want to share a little bit, a minute, just how much she's meant in my work now as a national consultant. Gillece has over 40 years experience dedicated to public mental health, working in institutions and communities. Joan has provided direct service, administrative leadership, training, and support to adult and juvenile services, courts, substance abuse, and other healthcare programs, as well as numerous community-based initiatives. Joan and colleagues developed the nationally used TAMAR program while at the Maryland Department of Behavioral Health and funded by SAMHSA. Her focus is implementation of trauma-specific, peer-led, strength-based support across systems through a social justice lens. She's currently the director of the Center for Innovation in Health Policy and Practice at the National Association of State Mental Health Program Directors, where she works nationally, providing consultation, training, and assistance to publicly funded systems. And just to sort of bookmark where Joan fits in Northeast Tennessee, when I was working for the Johnson City, Tennessee Police, with an $800,000 grant, my probation program manager and I attended a conference where Joan was a keynote speaker, and literally the information that she shared, it changed the trajectory of my career. I felt we should train our town, so I invited Joan, who came in October of 2015 with her colleague Dr. Brian Sims, to the ETSU Culp Center, and some of you here today were a part of that. And then Joan came back in 2018 with SAMHSA members to see how the work had grown, and she is definitely a true champion in this science, and I'm delighted to call her a friend and a mentor. And so with that, we're going to turn it over to Joan. Thank you.
Yes, thank you, everyone. And you know, when I think about that, one of those first times at ETSU, number one, your president was incredible in the things he was talking about in terms of community-based supports. I thought I just sat on the edge of my chair listening to him. But one of the other favorite people I heard was a principal of a school, a high school for kids that had struggled in the traditional high school settings. And she was talking about what she does differently to support these kids. And she rode the school bus in the morning. I thought that was brilliant. She knew those kids needed that from the beginning. She said, I had to drive in. I might as well get on that bus. And I use her example lots of times. Lots of times principals hear me say this and say, you've got to be kidding me. You expect me to know. I'm not saying I expect you to ride the bus. I'm just saying when people really understand the cultural shift that needs to happen to implement practices that don't do no more harm, what she did was this creative thing that I didn't read in a psychiatric journal. I mean, this came from her understanding it and understanding that every intervention can be a therapeutic intervention. And guess what? You don't have to be a therapist to be therapeutic. Some of the best therapists that I know are not therapists. They're the officers in the jails. They're the direct care staff in the hospitals. They're the people that oftentimes get the least amount of support, the least amount of respect, the least amount of opportunity to learn. We oftentimes train them to what you say, what you do, but to learn where behaviors come from. So then they can use their own good creative judgment to get in front of things before they go south. You know, we're very good at crisis. We're not real good at prevention. So how can we work with all these different folks across systems to be able to understand where behaviors come from, where they originate, versus us trying to just address the behavior? And this is my work. After doing this work for many, many years, I started volunteering in the state hospital in Maryland when I was 15 years old. And I'm sure it was about what was going on within my own family. I was raised by a single mother. My father died very young. My mother raised 4 kids. My mother had a pretty serious psychiatric challenge. And I think that I must have started that to be able to understand more what was going on within my own home. And I really started to understand that, you know, so many of the things that we see and so many of the behaviors that people do are really what we can do to be able to protect ourselves from feeling that pain again. So we develop adaptations to that pain. And so that's really what has driven a lot of my work. I started out in the forensic hospital. I started working at our maximum security hospital for folks who were found not criminally responsible. I did that for 15 years, working with folks who were involved in the courts and also had a psychiatric diagnosis. I then became the assistant director for the state mental health system, and I had responsibility for individuals who received their mental health services in non-traditional settings. So I had the jails, the prisons, I had homeless programs, I had substance use, I had people living with HIV. I kind of had everybody that wasn't just in the state hospitals or the mental health clinics. And I had a grant, this had to be 25 years ago, from SAMHSA. I was trying to just do working in the jails and trying to do parity work for women who were incarcerated. And we were doing an evaluation. We had to do an evaluation, and the University of Maryland Department of Psychiatry was doing the evaluation. So we started interviewing women that were coming into the jail. And just by chance, we asked about trauma. This is way before people were talking about trauma-informed care. And it was just a question we asked about abuse, in addition to how many times you've been arrested, what meds are you on and on. There's one little slipped in about abuse. And we found 25 years ago that over 85% of these women were telling us back then that they had been the victim of early sexual abuse, physical abuse, abandonment, neglect, right? So that changed everything in my world. So what I realized once I understood the impact of trauma was all the other populations I was dealing with, whether it was in the state hospital, substance use, homelessness, that thread that linked all of these systems together was that experience of untreated early and ongoing trauma histories. So whether you're in an orange jumpsuit one day, and then you're in the state hospital, or then you might be trying to get services from homeless programs, or substance use, everyone had behind those behaviors the same experience. Does that make sense to everybody? You're probably seeing it in the systems that you work in, that you see the same people coming in again. Or I go, just recently, I'll go to the DC jail where I'm doing a lot of work, and then to the public psychiatric hospital. It's the same person that I've seen a week before in either setting, right? But no one is getting at the cause, right? No one is getting at, why is this person rotating from system to system? Why is this person self-injuring? Why can this person not get clean, right? And instead, we pathologize, which are often understandable responses to really unfortunate situations. It's much easier for us to diagnose, you know, the kid in the juvenile justice system who's disruptive, right? The kids who won't go to bed at night, the kids who are injuring themselves, whatever it might be. It's easy for us to diagnose oppositional, defiant, attention seeking, manipulative, and then they get to the adult system and we call them borderlines, right? But what do we know that happened earlier? What happened in their lives? So when I work with the officers, for example, in juvenile justice systems, and really help them understand where it's coming from. I had one officer years ago who was really hardcore, telling me these girls were just disruptive and attention seeking. She said, I get it now. When they're banging on their doors at night and I think they're manipulative, attention seeking, whatever, what I understand now is things happened at night. And when I put them in that cell and lock that door, whether you've been a victim of abandonment or neglect, it's going to bring up those feelings. Whether things happened at night and you're locked in there and you can't escape, you're going to have those feelings. So this is this incredible officer who says, you know what I'm going to do? I am going to read them books at night. She said, I get it now. I get, these aren't bad girls. These are scared girls. These are girls that bad things have happened to. So she started reading to them at night. The girls got their blankets and she said, this worked for my kids. Why wouldn't I think it would work for these kids? So then that was working so well. She started reading them their history books at night because she knew the girls that oftentimes had the most difficulties, the kids that would go to school and then get sent back to the tier, that come back to the tier, and the staff would say, what's the matter with you? You can't even sit still in school. You're going to lose your privilege, right? What she realized, no, they've already been shamed and humiliated. She started reading them their history book. So what happened was those girls who were having the most amount of difficulty cognitively, you know, US history is about your priority number 0 when you're in a juvenile justice facility. So she started reading to them at night, those books, their US history. The kids would go to school and guess what happened? They could sit still. They could participate in their education. Everybody felt good. The girls felt good, right? The teacher felt good. The officer felt good, all through her understanding that there was meaning behind that behavior, right? There was meaning behind why they weren't sitting still. Instead, what we do unintentionally in so many of our systems is we further humiliate and shame, right? And so when we think about the difficulty of implementing trauma-informed practices, it makes us think really differently about our level systems. Think about how that feels. I was in a program once, there was this child who was adopted from Russia. His parents died. When his adoptive parents died, he comes into a facility. He had a foster mom. He was really challenged, tons and tons of trauma. And I go in and I see they had just presented this kid to me, and they had this very cute board up with these little mini cars that you could move across to see what level you're on. You could go from 0 to 100 and your little race car would move across. And sure enough, the other kids were at 70, 80, and he's at 0, right? The kid that had the most acute needs is at 0. What a way to let's tell everybody how much you're struggling, right? I kind of moved him up a little bit. I'll tell you all a really secret. I was like, let's just try to move this car up just a little bit and see what happens. But that was just something he saw every day that reminded not just him, but of the staff that he couldn't participate in that program, right? That shame, that humiliation. Does that make sense to everybody? So we do this inadvertently. So through all the work that I've done in all of these multiple systems, and weekly I'm in a jail, in a state hospital, in a crisis services, not just training people, but really being there. And we start with the voices of people served. What would make a difference? Help me understand what would make a difference. And we work from that. So we're really into flipping things upside down. Most of us have developed programs from our conference room and from our academic self, but really it has made such a difference to me and my colleagues to start by gathering the people served. What do you think would make a difference? And sometimes it's the opposite of what we think would make a difference, but it's not off the wall stuff, right? It has made us realize that we could comfort rather than control. And in that comfort, we get that control. So our work now is really about healing, the concept of healing. I had a kid in a juvenile justice system say to me, and he's doing our program, Tamar, that I'll tell you about shortly, our psychoeducational program that helps people connect the dots between things that happen to them and the behaviors that have ensued as a result of it. And he said, do you think the fact that I saw my father dead with a needle in his arm might be why I started getting in trouble? Well, yep. But instead, he was arrested for carrying a gun and selling drugs, right? He was in a facility. No one had asked him what happened. No one knew what happened to him and what started him down that road. And there's a story behind all of the folks that I see multiple times a week, no matter whether they're on the streets, no matter whether they're in a hospital, no matter whether they're in jail. There is a story behind it, but we never look at the story. We control that behavior. We look at, how to put the fire out, but we oftentimes never look at what started the fire. And that's what our work is about. So my work has really shifted into the concept of healing. I have a friend who was running the women's jail in Hawaii, an amazing guy named Mark Patterson. When women come into his program, now the first things the officers were told to say is, while you're here, you have to do your time. But while you're here, we want to help you heal. And here's a big one. We forgive you. You imagine what happened to violence in that facility? Went down to next to nothing. We want to help you heal and we forgive you. There's no shame there. Admission into programs is oftentimes unintentionally, of course, shaming folks, right? So we're taking away that shame. We're taking that humiliation, because when we have that shame and humiliation, what we know how to do with it is to protect ourselves from it again. So he eliminated that. Healing and forgiveness. Can you imagine? He then had the women growing organic vegetables in the garden because he wanted them to plant the seed that grew the vegetables that fed the community. Brilliant. He said, they've never been successful. I want them to be successful at something. He then had the young girls that are coming in all angry and tough, serving their elder their tray before they had that tray. Just elevating that dignity, that civility. So there's so much more than just the clinical work. I'm a clinician myself, so the clinical work is absolutely important, but also the work that people do 24/7 when the clinicians are gone. And that's where my heart lies really these days. I do every Tuesday, I work with the folks who have their annual reviews and new hires at DC Department of Correction, just about trauma. And it ends up being not me lecturing and showing a bunch of slides. It ends up being almost like group therapy, and them telling me about what it's like for them to be disrespected, to have someone spit on them, to be having to do overtime, to be blamed for everything. So we try to change that around, and we try to really listen to what their needs are. And what they've told me is they need peer support, officer to officer peer support. Because if something happens to them, if somebody spits on them, disrespects them, whatever it might be, they're left to sit with that by themselves. But if they had someone that really could help them through that emotional stuff that they do, then perhaps they wouldn't hold on to it and take it home or take it out on the people that they serve, right? So listening to them, we do work on the units with the officers, getting them to understand their own trauma as well as the trauma of those in their care. We do the same thing in public psychiatric hospitals with the direct care staff, who are often told how to fill out paperwork, how to, debrief after an incident to show what they could have done. But they're really trained on even understanding what mental health is about, what trauma is about, where psychiatric symptoms come from. So just taking it from that level and starting with the people that have the most contact with individuals served, because they're not the ones that can oftentimes come to the conferences or get to go to the meetings. And they're the most important people because they're the ones that have the most contact with individuals served. And whether you're in a crisis services, whether you're in a psychiatric center, whether you're in community mental health, whether you're in outreach workers, that's who has the most contact with those served. And sometimes, and I hesitate to say this, but it's kind of true. Sometimes almost the more degrees we get behind our name, the less contact we have with individuals, or the more protection. During COVID, working in publicly funded systems, I would often find that the clinicians, even if they were in the hospital, would telehealth into the unit because they didn't want to go in the unit, right? Understandably, there's this virus going around, services cut down, everyone was on the units 24/7 or in cells 24/7. And so they would telehealth in, but those direct care staff were the ones that had to go in. And it's the same thing with the officers. So we really look, if we're going to implement these practices, we are going to honor those folks as equally as we honor the clinicians, the academics, those that create the programs. And that's a hard thing for people to do. I'll say to folks, in programs, the folks on the unit 24/7 or the officer, they need to come to this training. They're like, well, who's going to watch the units? And I'll often say, how about you guys? Well, sometimes that works. And sometimes we're not trained. Well, you should be if you're running this place. And so, but when they do it, they come back and they say, that rule I made was the stupidest thing I've ever seen. I was making these rules from the front of the house and expecting people from the back of the house to implement them. And they were ridiculous. One warden said to me, I had this rule that you couldn't take your blanket off the bunk. So this woman will come in 10, 15 times a year into my jail. First thing she did, she took her blanket off her bunk and she crawled under her bunk. And that was the rule. You do not take your blanket off the bunk. So my officers were trained, she cannot do that. So she'd come in, she'd take her blanket off the bunk, she'd crawl under her cot, and the officers would say, you have to do that. You're not allowed to do that. You have to put that blanket back. Well, she got scared. She'd go further back in the back of her cell. The officer then would unlock the door, the cell door, would help her remove that blanket, meaning grabbing that blanket. An officer would get kicked, all hell would break loose, right? And he said, that rule that I made for no good reason other than control, I wanted to keep a really tight ship in there. That rule harmed his officers because that officer would get kicked or hurt or something would happen, right? Over this ridiculous rule that made no sense. And what changed him was when he learned about the impact of trauma and why she was getting under a bunk. And he became one of my biggest advocates. He was one of the hardest core wardens you've ever met in your life. He was this, he came from down country and he was going to run that tight ship. He became my biggest advocate. And he said, you know what? Once I learned about trauma, I learned that she did that to feel safe. She wasn't doing that to break the rules. She wasn't doing that to be defiant. She did it to feel safe. So these are the kinds of things that I will just tell you, example after example after example, that happens when everyone is included. And I am working now juvenile services in DC. I have the dietary staff as engaged as the clinical staff, as engaged as the social workers, because guess what? Food is really important. in juvenile services, right? And for them to say, we so appreciate this opportunity. No one's ever engaged us in this kind of work. But there's a lot that happens over food. I was in a program for trafficked women, for human trafficked women, and there was this big conflict about people putting food in their room. The staff, they're taking food in their room and it's going to draw rodents. I'm like, okay, let's think about why are we taking food into our room when I'm a woman who's been trafficked and on the streets, right? Nobody thinks about that. We thought about you're breaking the rules. And some people, if they break the rules, you lose all sorts of privileges, whatever, but no one looked at why is this person hoarding food? So then when we got through that, we thought about different ways to do it. A little mini fridge at the end of the hall, something. I mean, figuring out how we can, again, make sure those women can have that food when they need it, right? When they want it, versus making this rule that no one can have anything, right? So it's really rethinking some of our passed down since the beginning of time rules that we have. So to start off with, I guess you're showing my slides because you're ready for me to stop, right? Get those slides going, right, Lisa? Okay, you can do the next slide, please. So what I live in part of a world that has quite a few academics, and we do quite a lot of research and papers. And during the pandemic, I started reading a lot of stuff that I should have read in college and a long time ago, rather than the Cliff Notes. And here I was reading Tolstoy, and I think this was from like 1863 or something. It was 1873. And Tolstoy said, it's easier to produce 10 volumes of philosophical writings than to put one principle into practice. How true is that? So next slide, please. And again, so that is why we really try to start with the individuals served, no matter where they are. I mean, you can sit in the lobby in a mental health clinic, or you can sit in wherever, HIV clinic, wherever it might be, wherever your work takes you, and to just say to people, what could we do? What would make a difference? What could we do that would make a difference? What's working? What's not working? And you'll be surprised at what you hear. So I love this quote. This is with Ashley Warner, and she says, beneath each behavior, there is a feeling, and beneath each feeling is a need. And when we meet that need, rather than focus on that behavior, we begin to deal with the cause, not the symptom. So again, behind each behavior, there's a feeling, right? You can think about in your own life and with your partner, with your children, whomever, but beneath each behavior, there's a feeling. And beneath each feeling is a need. And when we meet that need, rather than focus on that behavior, we begin to deal with the cause, not the symptom. Next slide, please. So when we're thinking about trauma and we're thinking about implementing trauma responsive approaches, what's really important to think about is what happened. I had a colleague of mine who was a psychiatrist in the criminal justice system, and he asked a resident, an incarcerated individual that came to see him in the jail, he tried this. He said, tell me what happened to you. And the guy said, well, I robbed someone, I had a gun, I got arrested, and here I am. He said, no, I don't care about that. Tell me what happened. And this particular individual said, no one's ever asked me that. No one has ever asked me that before. What happened to you? The other thing is, your symptoms are frequently adaptations to traumatic events, whatever it might be. You might see individuals who cut, you might see individuals who become dissociative, you might see individuals who just can't get clean, who get in bad relationships, whatever it might be. Those symptoms are frequently adaptations to things that happen to us. You might see people who, had a car accident and they will drive all around, but not go near that corner where they had that accident, right? Or people who uh, who have a lot of anxiety, people who are constantly responsive, hyper aroused. Some of the symptoms are really adaptations to those traumatic events and what we do to protect ourselves from that trauma happening again. And the other thing is healing really happens in our relationships. Oftentimes, individuals who have had serious trauma in their lives, when they tried to tell, they weren't believed. They were told to keep that secret in the house. It was ignored, and they never again spoke about that trauma. That trauma lived in their body. That trauma lives in your body, and the healing happens in relationships. So, next slide, please. So, working with SAMHSA several years ago, we brought together clinicians, we brought together trauma survivors, peers, academics, to come up with a definition of trauma that wouldn't be something that particularly would end up in the DSM, but would be as relevant in all of these different systems and in our own personal lives that we just talked about. So we came up with this definition that individual trauma results from an event or a series of events or set of circumstances that's experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning, whether it be mental, physical, social, emotional, or spiritual well-being. Next slide, please. So an easy way to think about this is the 3 E's. An event, something happened. You had that car accident. You witnessed violence. But what makes it traumatic is that individual experience of that event. What's traumatic for me might not be traumatic for you. And then the long-lasting effects of the trauma, whether it affects us socially, emotionally, spiritually, those adverse effects of the trauma. So it's the 3 Ds: event, something happened, that experience, and the long-lasting effects. And this really resonates with people. After the uprising in Baltimore City, when Freddie Gray was murdered, we worked a lot with the police department. And I had one officer, his job was to go to shock trauma in Maryland, University of Maryland, and to deal with people who were shot, whether it was police officers, which unfortunately happens, as well as community members, which unfortunately happens, and their families. And that was his job. And he told me that he would come home, and his wife was a hoarder. And he said, I'd come home after these terrible, hard days, and there was stuff. She had been to yard sales and to Walmart, and my house was filled with stuff. And he said it was wrecking my marriage. And so he said, understanding trauma has made me a better cop. I'm not going to pull my gun out as fast. I'm going to understand why I might be having these responses that I do, because I've witnessed so much violence. But it's going to make me a better husband. So my wife, I now realize, grew up with housing insecurity. She was either living in a car with her family, she was in shelters, she was going from cousin to cousin. And I'm realizing now that hoarding behavior was really what made her feel safe. And this is going to change the way I address it. And actually understanding this is going to save my marriage. So we're looking at that event, that experience, and again, those long-lasting effects. What's traumatic for me, not traumatic for you. We were working in a program in Brooklyn, New York, with the Orthodox Jewish community that was serving individuals who were Holocaust survivors, women survivors, and one of the therapists told me, you can go back to that. Can you go back one, please, Lisa? Yeah, is that, I think you have to go back one, back, there. Oh, no, that's good. Next one, please. Next slide, please. Yeah, you can hold on that for a minute. And so what one of the therapists said, she said, I went to this lady's house, an 83-year-old Holocaust survivor, her little efficiency apartment, and I had on black boots. And this lady said to me, you may never wear black boots in my house, my apartment again. Well, when we realized the black boots, she was put in a camp when she was very small. She was 3 years old. And to see the Nazis, to see the black boots and the top of their black boots was the response that she still had. Now, she's living in New York. Everybody's wearing black boots in the winter, but that doesn't mean everyone who's a Holocaust survivor is going to have that same response to that black boots, but she did. So she was triggered every time this therapist came into her apartment, but no one knew. So again, that individual response. And that's one of the reasons it's difficult, I think, for us to treat the trauma, is because it isn't one size fits all. We all have our own individual traumas and our own individual responses. So again, back to things that I should have read a long time ago. Here's Huxley again from the late 1800s that said, it's a little embarrassing that after 45 years of research and study, the best advice I can give people is to be a little kinder to each other. And you know, that's really true. Our work, we oftentimes have to start from the beginning at intake. We start from the beginning at the receptionist. We were working with an HIV clinic in Baltimore City. There was a woman who was getting her meds from the clinic, serving HIV, serving people with HIV. She was always late. The receptionist sees her coming in. She says, what's the matter with you? You're late again. You're 20 minutes late. We can't see you today. This woman left and never came back. Again, that shame, humiliation. Come to find out, this woman had 4 children. She had to get bus tokens. She had to get childcare. And what we had to do is start to work with that, with that receptionist to say when she comes in, we're so glad you're here. Even though this woman never came back. We're so glad you're here. We know how hard it is for you to get here. If you can sit down, we'll get you a glass of water and we're going to fit you in. Instead of the whole waiting room hears her be chastised. And again, that shame and humiliation once again. So next slide, please. So a lot of our work, and I'm sure with you all in Tennessee, crisis services, crisis mental health services, 988 implementation is really a national priority and a priority for SAMHSA, who funds us. So again, starting with individuals who are doing the work, starting with the individuals that are on the ground, I'm going to share with you, and when I give you my how to get in touch with and how to use all of our products. This was one that we did on crisis services, just a little minute or so clip of going onto the streets, going under the bridges, meeting with people where they're at and hearing from them. So here's the first clip. Lisa, if you could please play this.
When someone dials 911, it is probably the most difficult and traumatizing experience they're having in their life, right? There is an emergency happening and they need help.
When you call 911, it's the worst day of your life usually, and something serious is happening. And sometimes somebody else is doing it to you.
Every call for service that we go to is a traumatic event because it's something different. It doesn't involve us. But if we can help them and ask the appropriate questions, then that will help the community.
Well, when you take on a role like this, the crisis response team, which is obviously comprised of officers and clinicians that are responding to calls for service that are related to behavioral health, there's a much more human component to what you're doing. You're really trying to connect with someone, not just on a surface level, but a very much deeper level. You know, you're learning things about a person, or sometimes groups of people that aren't readily known or made easily available to just the general public. These are people that find themselves in unfortunate circumstances and acute level crises that really are reaching out for help. I mean, that's a really vulnerable position for someone to be in. To do that, they usually have to divulge a lot of themselves and their personal information and their history, their family dynamic to you, to really be able to dig in and provide help. So it's a much more personal experience doing this type of policing.
So Lisa, could you go back to the first clip, please? I think that was the second video, maybe the first one. There we go. Thank you. This is the voice of individuals served.
My story is not just my story. You know, it's like my story is not my story. My story is about multiple stories that I've picked up along my path. Like from New York, from Georgia, from Oklahoma. This is my 23rd area that I've been in. I've been through a lot of different states, and I've talked to a lot of different people that suffered worse than I've suffered, and hearing their stories helped me. And I look at it like, well, if they went through it, I can get through my situation. You know, I talk to people.
Sometimes that's the easiest way to break down a barrier between policing and community, is to have a conversation. I wear a uniform, but I'm just as human. I make mistakes. We're all human. Realizing that the normal is not being normal. And the definition of normal should not be a simple definition or a blanket definition, because there isn't an easy normal.
The best thing, honestly, is just to listen to what they're saying and try to find something to relate to it. And it might just be as simple as no one in the house that they're at listens to them.
Anybody that I come in contact with, and I'm out here on a regular basis, anybody that I come in contact with, I am listening to what they're saying, actively listening. Because what I found when I was out here was that the only thing I had left was my voice. You know what I'm saying? Just to have somebody listen to me. And see, with a peer, it's different because we don't have a time frame. We're not in a hurry. You know what I'm saying? We're not going to bill for that 30 minutes or hour, in real talk. You know what I'm saying? So I got 30 minutes to sit here while you smoke your cigarette or drink your coffee, and let's talk. That's the beauty of being a peer, because you can really take time to let a person have their voice.
People who have healed can help heal someone else.
Okay, we can go to the next slide, please. So this is just an example. I'm going to share with you all of our products for you to use as you want. We have several videos. This one was just that we did just on crisis services, but we have many. We have it on serving individuals within the LGBTQ plus community. We have it on in jail services. We have it on the street services. We have lots of videos. So as we conclude, I'll share those links with you. You know, another quote that I just love is, to understand another person, you must swim in the same waters that drown them. And some of the things that we learn by really working with individuals who perhaps are some of the most disenfranchised community members is really to be able to have that empathy, to listen. I was working with individuals. They brought some individuals out of solitary confinement in a jail a couple months ago. And one of the guys who, you know, they're locked in 23 and a half hours a day. They come out to meet with me. They're in their belly chains and shackled and whatever. And he said to me, could you ever feel better after you shoot someone? You know, that was kind of a first time somebody had said that to me, but I said, well, explain what you mean. And he said, I shot and killed the person who abused me my whole life. So we talked about that, but then we talked about gun violence, and we talked about empathy and what happens when we bury our empathy. What happens to the developing child or whatever when that empathy is no longer there, when we bury that empathy. And he said to me, I don't know anything about empathy because I've never had it. I've been on the street since I was 14. I've never had it. So I don't even know what it is. So it really got us into this discussion about, if you have empathy, is that going to keep you from the violence, from the shooting, from this, everything, you know, you guys have certainly witnessed enough of it in Tennessee. I mean, what happens, and where does that empathy go? And are we thinking about gun violence in kind of the wrong way? One of the reasons why we started another program that we did, and you'll be able to see it when you go into our website, is called Triumph Over Trauma. And we did this because when we were working with crisis services, we realized that lots of people in community don't have any interest in going to community clinics, or it doesn't have to be a mental health thing. But as NA and MA and AA often occur in faith-based settings, why couldn't we also do the same thing with trauma? So we took our TAMAR program, trauma, addiction, mental health, and recovery program. And we pared it down to 7 modules, not the 16 modules that we normally do. And we brought together different faith leaders, whether Islamic leaders, Jewish leaders, Christian, Native American, to be able to take these concepts of understanding trauma and adapt them to make them most relevant to their own to their own practice, whether it's using readings or hymns or whatever it might be. So then, as people can do the NAAA, you can also offer these Tamar groups within faith settings. There's trainings that we've done online for free for faith communities to be able to do this work. We're also doing it in several countries in Africa. Women actually of the United Methodist Church, ministers have been carrying this out in villages in different places across the continent. So we'll share all of this with you. The thing that is about all the products that you'll get as we conclude, we really we don't have anything to sell. Nothing we have is cost any money. We don't really care if you have fidelity to these modules when you see our trainings and when you see our interventions, our group interventions. We want people to use them and to adapt them that ever makes the most sense for them. We have a Spanish version of lots of our work. We have a youth version. So to be able to take this and not have to start from scratch and be able to use it, everything comes with a manual, so people can use it wherever they see fit. And again, we want you to customize it for your own needs and no charge for anything. So next slide, please. So one of the things that I do when I go from different places to different places each week is, I really try to look around and look in the communities that I go to and where are the programs located. This is Baltimore City, and this is the heart of the inner city. And this is a program that I visited for women and children, women who are have had housing insecurity, women who've been incarcerated, women who have struggled with substance use. So this is their parking lot. And when I pulled up into the parking lot, this is honoring someone that was killed right in their parking lot a week before. So the women told me, they said, we're recovering, we're healing now, and we're afraid to let our children outside. We're afraid to get outside because, again, although this is honoring someone who lost their life, it's also a reminder to us of how unsafe our communities are. Whoops, I think we lost our slides here. Lisa, did we lose our slides? Here we go. There we go. Thank you. Thank you. So again, this is a reminder. Next slide, please. Nope. I think there was something before that. There were some pictures, maybe. Nope. Is that the next one? Okay, go to that one. That's right. No. Next slide. This will be fine. That's good. So what these women tell me and what I've learned, and I mean, it's a little bit controversial, I know, but what I learned, and mainly of women of color, who have said, I dream of never being called resilient again in my life. I'm exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or how many. I know that's not what we intend it to be. I 100% understand this. Excuse me. But I just want everybody to understand that this is what I hear when I am deep in community, that I've had someone say, when I hear resilient, it just makes me think that you all want to teach me how to suffer better. Understanding that this has no intention. This is not what anyone has intended, but sometimes when things get translated down into the people that need the most support, sometimes this is the feelings that I'm hearing. So after speaking, with those women in that program, these are some of the responses that I got. So next slide, please. So in terms of what's important and how we oftentimes treat our most disenfranchised community members, this is on the grounds of, you can see Department of Health, that sort of has homeless programs, psychiatric emergency programs, as well as medical services. But this sign, we worry about HIPAA, and this sign to me is one of the most offensive ever, because I don't think in private hospitals we're going to see these kinds of signs. But again, it's further, that shaming and humiliation that we do inadvertently. We brought together once a dozen judges and a dozen recipients who've been in front of the drug courts, and we wanted to just learn from each other. So one of the women who has been in the drug courts many times, she said, when you have the docket, the judges have the docket, who did well and stayed clean that month, and you have the docket, we've already done our urinalysis, who struggled and who had a positive urine and has to take a consequence. They said, but when you are on the bench and you have your microphone and everyone in the courtroom hears that I really screwed up, the only thing I know to do with that shame is to use, because that's how I cope. The only thing I knew how to do with that humiliation is use. So she gave the judges this idea. She said, you have the docket, who you can see everybody first that did well, and then those of us that struggled, we can approach the bench individually. You can let everybody else leave the courtroom. We can approach that bench individually and we'll take the consequence. But it reduces that likelihood again of that shame and humiliation. And the judges loved it. They said, we never even thought of it like that. But again, listening to the responses and listening to what would make a difference for individual serves can oftentimes make a huge difference in people's behaviors and in people's recovery. Next slide, please. So this is a hospital in Baltimore that serves the same population as the slide that you just saw. But what a different vibe. This is St. Agnes Hospital in Baltimore. And this is how you enter into that hospital. May his dear sheltering wing be over you through all the storms. Very different way of people coming into the same services that they were going to with that horrible sign that's been around for years. And I don't know why it's still up, but it is. What a different vibe. Next slide, please. So again, this is when officers get it. This is a juvenile justice facility, maximum security facility for girls. This is a secure cell. The bottom of this bed is cinder block, that terrible mattress on top. They used to have these gray, scratchy blankets that I think in every institution in America, it's what people have. It's whether it's a hospital, a jail, juvenile justice facility. The officer came to a trauma training with his warden, and he said, I get it. I get it now. Night difficult. He said, I'm an artist. I want to see if I can do anything to lessen the anxiety that happens when we lock people in. So this officer painted every cell. They then got these they made fleece blankets. They went to one of the Joanne's fabrics or whatever and got the fleece blankets, totally trained, totally changed how the girls responded at night. Now, I've had people say to me, well, you're going to do this and they're going to never want to leave. Well, yes, they will. They still want to leave. They're still locked in, but we're reducing the girls from being dysregulated, as well as we are reducing the likelihood of an officer getting hurt, because that's what would happen. I mean, that's what would happen with the struggle when girls banging on the doors at night, opening up in the door. How can we understand where those behaviors coming from so we comfort rather than control? Next. This guy was brilliant. He did every cell in the girls, then he went to the boys, and it made a huge difference. It made a huge difference in the behavior, just like the officer who read the storybooks, right? Just like one officer, when we're working with them, he said, these kids, when I was a kid and I had huge issues in my life, putting a sheet over a chair and making a fort made such a difference. And he figured out a way to get these drapes over the, the kids' beds there were bunk beds, and there was nobody in the top bunk, but there wasn't the bottom bunk. And he made these drapes that could go over underneath the top bunk and then down again, that could help those kids feel secure. So when we move this from this just a clinical kind of intervention, and we move it from diagnostic kinds of DSM kind of things, and we engage the officers, the direct care staff, the cops, the everybody in this, and allow them to make their own good judgments, this is what happens. Next slide, please. And this is the favorite. Just brilliant things that once they were just able to give that opportunity to learn, these are the changes that happen. And this is this cell that has the toilet sink combo in it. This was maximum security. So just what a difference it made for these kids, and how you felt going to bed. Again, if you're put in that cell, or you're put in that room and that door's locked, and you were a victim of trauma, of abuse at night, or you witnessed violence, or you heard violence, you are going to be dysregulated. So next slide, please. And I should add our TAMAR program that we developed years ago out of those first days in the jails that I started this talk to tell you about. And we developed it's 16 modules. You're going to be able to see it. You're going to be able to see the manual for facilitators. But what it does is it helps people connect the dots. So many people I see say, we had no clue that was traumatic. We just thought that was life. We had no idea. So you're learning. It isn't dynamic. The way I trained is much more psychodynamic, is versus this is psychoeducational. It's really not so much clinician needed. It's really about, we like to have a counselor or someone co-facilitate it. And in many places, we have a direct care staff or an officer co-facilitating these groups. But the beauty of it is, after each, and the last thing in each session is you're learning a self-regulation strategy. So you're learning about trauma, you're learning about these symptoms, but then you're learning, this is what I can do to take it down a notch. Whether it's breathing exercises or journaling or tapping or whatever it might be, you're learning after each session what you can do about it. And the reason why we have the officers or the direct care staff co-facilitating, when the clinicians leave in the evening, and those direct care staff, no matter where you are, you could be in a group home, you can be anywhere, leave, you can be in a medical hospital, you can be wherever, that when the people that are really in charge at those times can say, what did you learn in TAP today? Let's try to practice some of these strategies that you learned. Let's talk about, can you try that breathing exercise? Can you take it down a notch? So again, so many of the things that we are doing are prevention. It's about self-regulation. It's about people understanding that those responses are really adaptations to what we do. And it's about looking at how the whole milieu, everyone needs to learn this. In one hospital, medical hospital, and in a psych unit as well. But we were working with all of the people that were in the medical facility. And it served a really impoverished community in Baltimore City. And I was going into the training, and I had people introduce themselves, and the housekeepers were there. And I was like, wow, this is great. And this was under the leadership of an incredible sister of Ang Sakur, a nun, who, of course, had the housekeepers there. And they said, when the doctors are gone, and a lot of these folks were really intimidated, didn't want to talk to these people coming in white coats surrounding the bottom of their bed. But when the housekeepers came in to clean the rooms after the doctors left, oftentimes the patient, the person in that bed, started talking to them and started talking about things that they never would have with the doctor. So we developed these really trauma responsive housekeepers. So it elevated them. It really put them in a place where they felt like they weren't invisible anymore. They were these trauma responsive housekeepers. They got the same training. So it elevated them, and they felt a part of it, right? It was great for the people served, and it was great that we had the housekeepers being trained with the physicians. So again, it's leveling that playing field and realizing we all have an equal role to play Doesn't matter how many degrees you have, we're all equal in this important work. So now Maya Angelou, again, kind of what in my little office our motto is with Maya Angelou saying, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And so much of this is really about just that. And but it also has to start with everyone. It has to start with all of those that have the most contact with individuals we serve. You heard those police officers and how the things that they say and the way they're dealing again with individuals in the community now. It's all about them not being told what to do or what to say, or it's all of them just gaining this understanding of where the behavior comes from and then empowering them to be able to make their own good judgments on what a difference they can make. And they're all pretty fabulous. Next slide. So finally, again, here comes Dickens. No one is useless in this world who lightens the burdens of others. This is one of the reasons we love peer support. We do peer support everywhere. And sometimes it isn't just the certified peer support that folks normally have. It's like just getting people to, they are organically our peer supporters for one another, but really to help people understand that, again, you don't have to be that therapist to be therapeutic. We all can have a role to play in really lessening one another's pain. So next slide, please. So these are our resources, and I'll share with you what all we have. There's a lot of things that that we have that you are really welcome to use any way that you can. We have the trainings in Tamar, and that again is our intervention, trauma, addiction, mental health, and recovery. We have a Hispanic version, a youth version, the regular version that you can use. You can use whatever modules you want. You can discard whatever modules don't work. In one program in DC, that's a stabilization center that brings people off the streets in for 24 to 48 hours. We're doing one module. Once they are able to sober and able to absorb something, we start them in one module on understanding trauma and then teaching them some of the self-regulation strategies. So we're using it everywhere. We have lots of trainings that you're welcome to use. A lot of videos. You saw the snippets from the crisis one that you're welcome to use. We have one on the LGBTQ community, talking about what supports, particularly in mental health and substance use, what made a difference with them. We have one in jails on incarcerated individuals, talking about what a difference it's made in their lives and how perhaps if they had this when they were kids, they might not have ended up there. So there's all sorts of videos. We have one we did in Baltimore City on the streets. It's called Be More Kind. And it is with the police officers and their homeless outreach team, which is pretty incredible. These women officers that started this program called the HOT Team, the Homeless Outreach Team, and they have their vans filled up with food and socks and you name it, and they connect them to folks, to services, check on people. It's really a quite incredible program. We also developed workbooks. We knew that whatever we could do that people could use immediately made a difference. So we have a workbook that is in here, the wellness, the Tamar Healing and Wellness Workbook, that we did it for use in jails. Particularly, we did it right after COVID because we realized that people were in their cells for a long time with nothing. And if we could give them something that they could have used, would have made a huge difference. So instead, they have tablets, for example, in the jail in DC. So these workbooks are logged in. And again, it's addressing trauma, but it's a lot of exercises that you can do. We have used it in mental health facilities. We've used it, substance use, wherever. We've had anywhere in need. One of the most fun that we did was we did workbooks for kids. You can see there's a pre-kindergarten one, a kindergarten to second grade, a third to fifth grade. And it's really self-regulation coloring book kind of thing for kids. And you can see it gets older. It's this gender neutral bunny named Bing, and Bing grows up through ages a little bit through each workbook. But so the kids can project into Bing, the kids can project their feelings into Bing rather than us using this as a clinical intervention where they're talking about their own feelings. They're really talking about Bing and the thing that Bing goes through. And they can do all these exercises to help understand Bing's feelings. So these are all printable. Please use any of these things in any way that help you. The next slide has my contact information, although Becky certainly knows how to get in touch with me. We are happy to share anything with you to be able to support you any way we can. Our website also has tons of academic papers on about every subject you can imagine, and that's the one that's nasmhpd.org. That you can see all of our different our different documents that you're welcome to use. NASHCD stands for the National Association of State Mental Health Program Directors. So we represent and support all of the state directors, and now it's a lot of behavioral health, because mental health and substance use directors across the country. So each state has a member. Marie Williams is your member, representing your state. So that's who we are, and I think we have time for any kind of discussion or answers, questions, or anything that we can. I guess we have about another 20 minutes, 15 to 20 minutes, so we can.
I have a question.
Listen to whatever anybody has to say.
My question is, and I've been thinking about this a lot in the last year, as we struggle to introduce concepts and constructs that have labels that many describes off-putting, like you described, resilience or trauma. People don't want to hear about it, or they're tired of hearing about it, or blah, blah, blah. And so when I think about my white male upbringing, and I think about the culture that I was raised in, and what a role shaming was and humiliation was in male upbringing. Just, and I was relatively well-to-do. I wouldn't say we were low income, but we certainly weren't high income, but it certainly was the culture. And so when, my culture, I like to think that I got exposed in higher education, I learned things, and so I stopped being part of that culture. But when I go back to it, and I just see it all around me, like, it's just all the families, like everybody's raised in a culture where part of parenting is humiliation and shaming. And so it seems to me like if anything we're going to do here, we're going to have to change the culture. One place is male culture. Like, I don't know where, I don't know about all men who were raised anywhere, but certainly the culture in the neighborhood that I was raised in, Toledo, Ohio, had that. And it seems like, you mentioned about intervening with the frontline providers. In that case, it'd be the dads, I guess, maybe, or the mothers of children who are boys. But anyway, I think about focusing specifically on how men are raised in culture. And I go to these talks and I host a lot of these talks, and there's hardly any men who come to these things. And in the trauma literature generally, there's hardly any men who are doing that work. So I'm just curious about what role you think rethinking how we raise boys in our culture ought to be like a priority in any of this work.
I raised two of them, and that's my hair is white. Do you see that? But no, I mean, honestly, I really used to think that my goal is to raise two boys that aren't jerks, I mean, two boys that are good to women, and they are. It's really interesting. I don't think my kids have ever had a fight, and they're pretty incredible, but it took work individually to really be able to instill that sensitivity and also that trust that they can be. That's who they can be. And it's interesting you say that, because in the jails, the reason why we started doing it with the jails is the men wanted it. And I am blown away by, we started this work with women. I mean, back years and years ago, it was with women, because everybody was thinking it was women with trauma. The prevalence of trauma in the lives of these men that I see incarcerated is unbelievable. The sexual abuse is pretty rampant, the abuse in general, and then it gets buried in because people couldn't talk about it. So, we are doing it there. What we learned, the reason why we're doing the faith-based again, is the men said, we don't want to go to a mental health center. We don't want to get help with this, but they were okay with going to it in a faith-based community. Some of them. That's a whole nother story. I was also raised Catholic, so that's a whole nother story. But in terms of community churches and synagogues, that's made a difference to be able to get people to speak about it like that. The peer support, I think having peer-to-peer support and having those kind of groups together has made a difference. I'm not sure. We have a friend of ours, Mike Skinner, who writes an incredible blog, and I guess it has a newsletter called Surviving Spirits, and it's really about men and men's needs, who are survivors. Men that are also survivors. So, I'm not sure. I know what I tried to do with my kids, and how I tried to raise them. But the male culture, I am not an expert on that. I'll tell you that right now.
Tap into that, what you were just saying about the male culture and stuff like that. I find the barrier that I have as an older white woman trying to reach that demographic and create an understanding there. Talk about a culture gap. If I'm speaking to a young Black man or something like that, they kind of look at me and say,
yes,
that's huge for me, is trying to find a bridge to that.
It really is. And I think you're absolutely right. I am very clear about making sure that when we are going into a Black community or a Black man, that it isn't me doing it. We have a whole cadre of different folks that work with us, that I'm not going in as old white lady in there. That's not what I would do. I would send in someone else who was one of our colleagues. And that makes a difference. Or if I have to do it, if it's like a training, something, never by myself. I'm always having someone of color or whatever it might be to do it with me, no matter who I am, no matter where I'm going. You just need to make sure that audience, that you're matching that audience with someone who is also a member of that community. That's a really good point, because, a lot of the trauma women, when we first started this, are middle-aged or older white women. And I think it really has, it's been a struggle.
Would you have had that same sort of approach if you were working with a boy or a man, to get like a male co-therapist?
Yes, absolutely. Well, it depends. I mean, it depends, but yes, we're very conscious of that. And if I knew what was going on with that boy, yes. I even do that with my friends whose kids, or whoever needs something, that you want to make sure you're getting the person that you think is going to be the right fit. Yes, totally agree.
We have
Other
a few
questions?
more minutes. Are there any other questions from the audience? I've been looking at the chat. I haven't seen any questions in the chat, but we do have a little time if you want to unmute, or if you want to raise your hand, I can call on you.
Any comments? I'd be curious if this resonates, makes sense, figure out how we can pull this off. It takes a lot of work and a lot of time. And some people think, oh, we're trauma informed, and you write a grant now and you have to write your trauma informed, and that might be people went to one training. But when the rubber meets the road, it's hard.
This is Art from Nashville. How you doing, Wallace? Glad to see you.
Hello.
Haven't seen you since our last resilience meeting here in Nashville. I'm fortunate to have been able to craft a men's trauma healing course here in partnership with one of my faithful organizations, and I'm glad to hear what you're doing here, because one of our big issues right now, most of ours are ex-offenders, and they're in their late 30s and earlies. And one of the things I'm wanting to do is also address some of the issues of the younger men. And we have some contact with the juvenile justice system. And so I got on a little bit late, but just share a little bit of some of the things you've been doing, like doing with the juvenile justice system for young men, because I'm trying to, I'm trying to develop for our program a more human life course approach where we can get young men early. And, you know, one of the things I want to do is connect the guys back with their children. So just want to see if
Yes, good for you. I mean, that's great. We are in justice. We're just starting another project in the justice system in DC. Again, with the guys, they all have trauma histories. I mean, no question about that. These kids have told me, you know, they carried a gun when they were out. They're going to carry a gun when they go back out because it's the only way they feel safe. So we have a TAMAR Y. So TAMAR, again, is our group intervention, psychoeducational intervention. You can, if you look at our products, you're going to see it. It's TAMAR and their Y for youth. You can also call me if you can't find it, but it has a guidebook. It has a facilitator's guide. So if you wanted to run these groups, you're going to have a guide that's going to help you through each session. There's a lot of, you know, there's a lot of talk and a lot of understanding trauma, but then there's after each session, but at the conclusion, you learn what we call self-regulation strategy. So you learn something that can help you take it down a notch. Because oftentimes these kids are so dysregulated that they don't even have that ability to be able to take it down a notch. You know, you go from 0 to 100, and we want to help them stop at 50. And so there's all these strategies. So if you go on and you look at TAMAR, you're going to see TAMAR Youth and the facilitator's guide that you can use. There's a lot of music that we use to play for the kids. There's a lot of using different kinds of pop stars and whatever, and they guess which one who had what trauma. And so there's a lot of active things that the kids do. There's a lot of poetry. All of that is very active while you're teaching them about trauma, but you're learning ways to cope with it.
Are you working with therapists?
Pardon me?
Are you working with art therapists?
I love art therapists. Before I went in for a PhD, I have a master's in art therapy.
Well, hello there. All right.
So many years ago, before I went down the other path, I love art therapists. I think art therapists are incredible, you know, particularly because so much of what we've experienced is nonverbal. You know, sometimes we don't have the words, whether you were dissociative at the time and you blocked off that conscious memory or whatever it might be, but that nonverbal really works. And that's why we've really put a lot of those kinds of activities into the TAMAR manual. So my phone number, I think, was up there somewhere, and my email. So if you can't find it, what you need, just get in touch with me, and we'd be happy to share it with you. In juvenile services, I'll tell you, one of the things that we've done, again, is made sure we got all of the staff on board too. Because anything that you can do in that group can be undone in a minute when they go back to the unit and people aren't also, you know, aware of what we're doing. You know, the group might last an hour and a half, right? Whatever. But then when they go back onto the unit, if you have people that aren't also trained in why we're doing this, it could be undone. So that's an important part of it as well. So the staff knows what you're doing. I guess if that is it, you can go out into your 98-degree weather or whatever. I'm in Maryland, and it has been beautiful this weekend. It was like 100, 98, whatever. And now it's been like high 70s for some reason. I don't know why, but I'm not going to knock it. So thank you all for your attention.
Yeah.
And thank you guys for inviting me.
Well, thank you, Joan. I just wanted to weigh in, and just so grateful for all your stories and just the way you approach this. I can see often out in the field, this is really lost. And so it's really refreshing to hear you again today. And thanks for sharing with our collaborative, and keep up the good work.
Well, thank you. And I hope you guys all need to get in touch with Marie. Somebody's get in touch with Marie Williams, because she's so supportive of this trauma work. And she's your commissioner of mental health, and she's so supportive of this and of the faith-based. So I think to get Marie could be a real ally.
And if folks could access the evaluation form, just 5 really short questions, take you about a minute, and then a certificate of attendance will pop up that you can keep if you need that to document your time with us. We've been putting Joan's contact info in the chat, but we'll have it. We put a link to the PowerPoint in the chat so you can get those resources. But we can also pull those off for you all. We know that you're all advocates in our state doing great work. That's how you found us. So we want to support you all in whatever we can do.
You know, could you also put it up? I mean, it's Neely Hicks, Reverend Neely Hicks. And she does, oh my gosh,
well, if you send us the
I'll send it.
Whatever you want us to have, we can distribute to all the
that
folks.
would be great, because Neely is in Memphis and she goes to Glencliff Church. It's a really interesting church. They have built these tiny houses for people who are without housing but are medically compromised. So they have like 12 little houses on their church, on their property. They're doing all this trauma work. Has anybody ever heard of Glencliff? It's just I see you're shaking your head. What is that, Betty? You're shaking your head, yeah. And so Neely is really incredible, and she does a lot of the training on triumph over trauma. She does the faith-based trainings.
Well, we could get her to do a talk for us too. That'd be great. You send us her info, and we'll see if we can get her to do a resilience series talk for us.
She just did it at one of your statewide faith-based conference. I think the governor's office does it on faith-based. Oh, yeah. She did it there. They did a whole training on Tamar.
That's fantastic.
Sometimes it takes somebody from out of state to introduce people in state. That happens to me all the time.
Well, we're about 3 different states in one state. We're like east, middle, west, and we try to stay connected. But yeah, we're 3 different regions sometimes. So thanks for connecting us.
It happens to me in Maryland all the time. I've been in Maryland forever, and it's the same thing. So I don't know. It's just, but I will send you Neely's contact. I'm sure she would be happy to.
Fantastic. I'm going to be in Memphis in November, Joan. I'd love to look her up and plan a time to visit.
Oh, she's amazing. Yes. I will send you her contact.
Becky.
I will send her. She doesn't just talk the talk, she walks the walk big time. And she found us a couple of years ago because she said she saw so many people come into the church with trauma histories and she didn't know what to do. You know, and so it's not just up to the pastors, it's up to she's trained parishioners to want to be able to do this group, much like NA and AA. So I will get that right to you in just a little bit. I'll send it. Lisa's my great contact. I'll send it all to Lisa.
Yep, send everything to Lisa. That's perfect. Well, thank you again so much for being here and sharing your expertise and starting some conversations, I think, here in Tennessee.
Thank you so much. Appreciate you guys.
Bye.
Bye-bye.